Welcome to another episode of Foresight TV. I have as my guest today David Grabowski, who is one of the prominent thought leaders on healthcare policy, very involved, knows senior living, and we are going to have an amazing conversation right after this. Hey guys, Steve Moran here. So I think maybe I was slurring my words a little bit as I was doing the intro because I realized I'd forgotten to queue up the intro video. And so I was scrambling and talking at the same time. Should have just had Jay to do it. But David, thank you very much for joining us. I've got one little piece of business I've got to do here first, and then we'll get into the conversation. Foresight TV is brought to you by CARE. They are the anti-staffing agency. They use an Uber Lyft model to be able to provide you great team members to fill those empty shifts at a much lower cost than you would pay for a traditional staffing agency. If you're struggling with your staffing, and who is not struggling with staffing? If you're not, I want to hear about it. But if you're struggling with staff, don't run short. Don't use high-priced agencies. Use CARE. It will make your community better. And if you find somebody you love, you can just go hire that person and they won't charge you. They'll actually love you for it. And so we appreciate their support in what we are doing. So David, welcome very much. There are a lot of people who are already going to know who you are, but I'm going to start by just having you do a quick overview of who you are and what you do.
Sure. First, thank you, Steve, so much for having me on today. So, hi, everyone. I'm David Grabowski. I'm a professor of healthcare policy at Harvard Medical School. I study all aspects of long-term care across all settings, all payers. I also focus on post-acute care for older adults and all sorts of other services that older adults might use. So, once again, thanks, Steve, for having me on.
So when you sort of look at the landscape, and of course, our focus is a little bit more narrow in the senior living space, but where are the big issues?
You already mentioned it in the intro. I think the biggest issue today that I hear the most across every setting is workforce. Nobody can find workers, and that's true in nursing homes, assisted living, home care settings. And this has always been an issue, Steve, in these settings, but it was magnified during the pandemic, and we haven't recalibrated. And I'll just note two recent papers we've done. These are focused on nursing homes, but I think they're relevant to all settings, including senior living. The first was on immigration and just how important foreign-born workers are for long-term care. I recently presented at Argentum at their Public Policy Institute. Argentum was going on the Hill to sort of talk to leaders about immigration policy. Long-term care policy is immigration policy. Immigration policy is long-term care policy. Let's not get that confused. This is a super important issue going forward. And I don't think it's one that historically senior living leaders or long-term care leaders have thought about. The other manuscript that we recently published, and both of these were in Health Affairs, the second manuscript was just on the use of agency-based staff. And when long-term care settings can't find full-time, even part-time staff, they turn to these contract workers. They fill an important gap, but it's a high-priced gap, and it doesn't always lead to better quality, and that you have kind of more turnover, more individuals in and out of the building. So, Steve, we're seeing on the one side maybe foreign-born workers really be a source of stability during the pandemic. They tended to stay. Whereas a lot of native-born workers left. On the flip side of this, in order to meet that need, we saw a real influx of contract-based workers. I think going forward, how do we find more full-time workers, whether they're native-born, foreign-born? We just need more bodies in this sector.
So I'm a little bit of a contrarian on this. I mean, I'm not denying that we don't have a staffing problem, but there are a couple of things that I spend a lot of time thinking about. The first is that we churn through a lot of people. Recently, a few months ago, I had a guest on, Jeffrey Farber, and they've got a 10% turnover for their CNAs. And if you only have 10% turnover, you just have, which means it's a lot easier to stay full. And then we're working with a company who's got a new hiring platform, and they're sending huge numbers of qualified candidates. They use some AI to pre-qualify, and the senior living communities are just not acting on these applicants. And then the second part of it is we all believe this notion that nobody wants to work in senior living, as opposed to somebody wanting to work at Google or even at Starbucks, right? And so it's sort of cool. And I'm wondering if it's a big problem is how we operate and whether the narrative is wrong.
We have a terrible narrative. And I think if you asked my 11-year-old, you might think, well, she's my daughter. She knows about long-term care. But if you ask the next door neighbor's 11-year-old about what, senior living, long-term care, I think they'd give you a negative perception. And we have an image problem, not just about kind of the workforce, but even what we perceive this. And I think if you went to many of the senior living communities that around the country, you'd be super impressed. And actually, this is a great place to work, and there's benefits, and there's a lot of amenities. My dog just joined the chat here behind us. So,
Awesome.
hopefully he doesn't jump on me during the live feed here. But
if he does, I'm going to get mine to jump up. So
all right, awesome,
yeah.
awesome. But I do think perception is a big part of this. That we have a negative view of long-term care, and I don't think it has to be that way. And I do think there's some companies that have done a better job of this, but I do think nationally we have seen declining rates of individuals being willing to work here, and I do think we've seen an uptick in agency-based staff, and I think both of those factors point to kind of the need to reframe this job.
Yeah. And while, we love what CARE does, and CARE is doing a great job, there's no question that agency is not as good as your staffing. They don't know the residents. They don't know the routines. I'm sure you recall 3 or 4 years ago, McMaster, who was Trump's something in Trump's administration, his father had a fall. An agency, LPN, put him in a wheelchair out in public so they could watch him, and they found him. He had passed away in the wheelchair in the morning, and you have to wonder if they had full-time staff there. Maybe the fact that she was a part-timer obviously was horrible for their family. Horrible for the nurse who lost her license. I think she was actually convicted. And so it's just, a tragic outcome, and it's really important to fix. So let's talk a little bit more about the image of senior living. Washington Post in particular has been on a anti-senior living crusade since, I guess, December. I think 6 articles. The most recent one came out yesterday, where you were quoted saying something that was pretty innocuous. But again, your expert name, let me pull it up here again. I had it. It's a pay to play model. I don't quite know why they even bothered, but anyway, how do we respond to this? I mean, I think this perception it's really frustrating.
And I think it's really important, Steve, to separate out A Place for Mom from this longer series. So I think A Place for Mom, and it's interesting. I've thought a lot over the last couple of years, along with I know Bob Kramer's been a guest of yours, and Bob and I and Ann Tumlinson wrote a piece focusing on how do we give long-term care consumers, senior living consumers, the navigation tools to kind of match to the setting that best fits their need. And we published that in the Hill just so that it would be kind of policy facing, and policymakers would see this. But we titled it A Road to Nowhere, and we really don't have the navigation system to get folks to where they need to be. A place for mom is an incredible opportunity, but as I guess I said it in the Washington Post piece, it's a pay to play model, and so it's hard to trust the information you get there. I do think that's a part of this market that's broken, is that navigation piece. How do I know who the good providers are, who the providers are that can best meet my needs? Let's put that aside. This longer set of stories, I do think this is an opportunity for senior living to be a little bit more transparent about the quality of care that's being provided, what's being offered in these facilities. I often frame assisted living, stepping back from this series, as a success story. It's largely been out of pocket. It hasn't added to our national healthcare spending. It's given people what they want. You can see people voting with their feet. The tremendous growth over the last 30 to 40 years. There are quality problems, but I believe they're isolated in particular communities. And how do we get the data out there to say this is a problem community, or this is an area that may need increased oversight? Whereas most communities, I would imagine, are pretty high quality, or at least individuals are continuing to spend their money and go to these places. There's some pretty good signals here that have met sort of the market test. Whereas I think a lot of the big quality of care problems are over on the nursing home side, not necessarily on the assisted living side. So I do think, Steve, like separating this most recent piece, which I do think a place for mom is an area where we're falling short in senior living. Whereas overall there's I think a lot to like about where senior living sits today, and the fact that it's met this important need. Is it doing everything? Do I wish there was more of a middle market? Do I wish there was greater quality transparency? Of course. And the final point I'll make, and it's one I'm sure you'll want to get into, is I get asked the question a lot: should we increase regulation on this industry? And I think the industry is at a little bit of a crossroads right now. If I hear a lot of folks in the industry talking about, could we play in value-based payment models and population health models? Could we own our own Medicare Advantage plan? And there's sort of accountable care organizations, and you could think of some very kind of grandiose plans. If you want to play in those models, you're going to have to accept more regulation. When you begin to offer more health care, and you're sort of this more integrated model, you're going to get increased regulation. But I don't see there being a big change if it's just continuing to be sort of the models that we have today. I'd be curious to get your take on that perspective.
So I've talked to, I mean, you have much more insider knowledge than I do, but as I talk to people, my sense is that that the federal government, that our politicians have things that are a lot more interesting to fight about right now, and that there's not much appetite to create another agency to regulate senior living. I do think that so I'm in California, and we have OSHPD, which controls the building standards in the state, and they are very, very difficult to deal with. I think, I think the last new nursing home built in the state was maybe 10 years ago because it's such a difficult process. And so we've got lots of pressure in a lot of areas, and we got hospitals that are full. And I do think this value-based care is a very interesting way. And I think that, I'd be curious, do you have any thoughts about anybody who's maybe figured out how to really contract with the hospitals? Because I think sort of medically based assisted living can provide a huge safety or a relief valve for the occupancy pressure. So any thoughts on it? Anybody who's doing that well?
I've been talking about this for at least a decade, that this exactly what you just described is a massive area of opportunity. I had a project about a decade ago with the 6 largest assisted living companies, talked to all of them about what they were doing on the ground in this area. All 6 of them at that time, and it's the usual names that everybody on this feed knows, they all said to a person, "We're interested in that. This is intriguing." When I asked them some very basic questions about what's your capacity, what's like as a starting point, what's the rate of healthcare utilization, what's your hospitalization rate? Not a single company could sort of give that to me, even at a kind of crude or high level. It suggests to me there's still, at least then 10 years ago, were a lot of steps that needed to happen to get to where we are today. There have been companies historically, even back then, like Ericsson, that has their own Medicare Advantage plan. Other senior living companies have obviously gone down that path. That's really intriguing. It's not clear to me, however, that we've seen a lot of really strong integrated models, and I'd be curious if you have examples here. But I still believe there's tremendous opportunity. I just don't know that I can point to hey, this company and this company at a national level are doing this. There may be some local examples here and there, but I think there's tremendous opportunity, especially in bigger communities that have that scale where you can make the investment in clinical staff on site. There's opportunity. We're seeing right now, at least on the nursing home side, this huge increase in institutional special needs plans, which is just another form of Medicare Advantage, which, you have a nurse practitioner on site. There's also these institutional equivalent plans that assisted living could take advantage of. I don't know that a lot of assisted living companies are yet playing in that space, but it'll be really interesting to follow, Steve, because I really still, I said this was the future 10 years ago. I really believe today. I'll keep predicting it, and at some point I'll be right here. So that's the strategy.
Well, I remember it's been like 30 years ago. I had a friend, this was in Northern California, who was operating a nursing home. And, I was just a kid. And we were just talking about, I was soaking up information, and he was telling me about the story where he had like 8 of his skilled nursing beds who were contracted to the hospital that they had exclusive right to. And he was getting like at that time, like $75 a day for those beds, because he had to keep them available. And it seems like that opportunity today is available in senior living. But and a part of the problem is that senior living seems to be totally intimidated by the hospital system. And traditionally, it's been really hard that hospitals wouldn't talk to them. But I think it's time to restart those conversations. I just think it's a massive opportunity.
I totally agree. And I think historically, you're exactly right. I think assisted living companies, senior living companies have been really reticent to engage with hospitals, almost scared because they don't have a kind of a language or an ability to engage with hospitals. Today, however, you see a lot of hospital systems around the country at capacity. A lot of what we're hearing, especially here in the Boston market, I know it varies, and California may be different, even heterogeneity within California, but at least in the Boston market, we have individuals sitting in the hospital, sitting in the ED for long periods of time. There's real challenges with discharge. Some of those patients, it would be very hard to send to different settings, but there is an opportunity, exactly as you described. Could you contract with an assisted living company to sort of help with some of that discharge, almost like a relief valve here? I don't think that's how some initially conceptualize assisted living, but it's another opportunity in a market. If you have the capacity, if you have the staff, obviously, once again, we're going back to the earlier topic. Do you have the staff to actually stand up this model? But I really believe it's an area of opportunity.
Yeah, I've been here in the Sacramento area. All our hospitals are super impacted, and my wife was in a few months ago for about 15 hours in the ER, and she never got in a room. She was a bed in the hall. I have another friend who did have a bed. His condition was more severe, but there must have been 2-3 dozen people on gurneys in the in the hallway. Those people wouldn't go to senior living, but I'm sure there were people who were on the floor that could have easily been moved over into medical-based assisted living. That would be better for everybody.
It's a win-win there. Yeah. No, sorry to interrupt you, but there's absolutely a win-win here. Go
Yeah.
ahead, Steve. Sorry.
So, do you have thoughts on where the concept of hospital at home plays into all this? We don't actually allow it in California, but it seems like it's part of that opportunity.
It is, and I'm even hearing now in the Boston market, there's an innovative group of physicians here that are trying a sniff at home model, if you can believe it. So that's like
Really?
the
Yeah.
cutting edge. And somebody asked me, "Isn't that home health?" And I said, "No, this is a more intensive kind of rehab following a hospitalization." But I think the model has tremendous potential. I think what's challenging always. So one of my former roles was on the Medicare Payment Advisory Commission, or MedPAC, and kind of putting my former MedPAC hat on. I can imagine how that conversation would go. This is very popular with beneficiaries. It has a real opportunity to kind of relieve some of the strain on hospitals. It gives people what they want. The challenge is this just going to open the payment floodgates? How do we ensure that this is really services that are needed and that are being provided at home? Same thing with SNP at home. That with these are these individuals who otherwise would have gone to a SNF, and I think the hospital at home are these individuals who otherwise would have been in the hospital that are now being treated at home, or would this have been done on an outpatient basis? Would they have just remained in the emergency department? I think what is this substituting for? If it's substituting for high cost inpatient hospital care, that's a win. Same thing with the SNP at home. If this is substituting for facility based typical standard SNF care, that's a great thing. If it's substituting for home health care, not so great from a budgetary perspective. Maybe great from a quality perspective, but just trying to put both of those hats on. Your beneficiary hat, you love this. If you're the policymaker who's worried about a federal budget here, you're maybe a little more
Yeah,
concerned.
yeah. Maybe what you and Bob and maybe I get involved. We need to do a symposium where we bring a bunch of hospital administrators together with senior living leaders and talk about how to fix this. I think the opportunity is absolutely amazing. I want to spend a little bit of time talking about the nursing home conundrum. 6 months ago, probably a year ago, I wrote an article titled "The Nursing Home Flim Flam Game," and I sent it out for comment to all the senior living associations, and they were very universally unhappy about it. One particular one, I won't tell you which one. They called me up and yelled at me for 45 minutes because they hated it. I actually had just rewrote another version of it. I finished it last night. It hasn't been published yet. But there are all these constituencies. There are the nursing home reform people who want more regulation, more staffing. We've got the industry saying it'll drive thousands of beds out of the marketplace. And we can't possibly afford it, and there aren't enough people any place, and they're all going to go broke, except that we've got nursing homes. Every time one comes up for sale, they get bought at astronomical. I just love to hear you riff on this for a while.
Yeah, it's a great question, and one I get a lot of. Wait, on the one side, as you said, you have industry saying the minimum staffing standard, it's an unfunded mandate, it's going to put us out of business, and I don't even need to give you the rest of the argument. On the other side, advocates saying, we have all these nursing homes making huge profits, they're not putting dollars back into direct resident care. Who's correct here? And my answer is probably both. There's truth on both sides, and so the truth is somewhere in the middle. On the nursing home side, Medicaid's not a very generous payer, and I think has made the economics of nursing homes very challenging. The flip side, however, there's pretty good evidence that nursing homes are hiding some of their profits in these related party transactions. That's not going to be happy. That's not going to make everyone that's
Right.
listening today happy, but that's the truth. There's good research showing that when private equity comes in, they're these fees, these management fees, these related party transactions, they increase, and that takes dollars away from direct resident care. And so I wrote a piece with David Stevenson that we argued, and it's a very simple argument, that yes, if we're going to do minimum staffing, we also need to increase accountability. That they need to be kind of paired together. You can't have this requirement and then have nursing homes and advocates talking past each other. Let's get the data to figure out whether nursing homes are actually putting these dollars back into direct resident care. And so uh, I, I I think it's the minimum staffing standard in and of itself is just going to kind of leave us in this almost in this status quo where we can't kind of the stalemate where we can't break this. We needed we need to pair the minimum staffing standard with additional data, Steve, where we can actually unpack who's making a profit here. Do they need additional funds, or can they actually put some of those funds back into hiring more staff?
Yeah, I think that the transparency is such a big problem. When in the article that I wrote that'll publish probably next week, I think that one of the points I made is exactly what you said, is that each one of those bullet points is true some of the time. And what we're really lacking is enough transparency to actually be able to paint a complete picture. And it's a little bit like the gun control problem,
Yeah.
right? The pro gun people, they take the position that you should be able to have bazookas and hand grenades and cannons, and the anti gun people, nothing less than a total ban of guns. And of course, most people see that as unreasonable. But how do you know? And so I really, I really wish there were a way to do that. One of the questions I've been asking, maybe there's some data out there, so you might be the person who can help with this. There are some states that have staffing standards that are already at or close to what the new proposed rates are. What's been interesting to me is I don't see either side going to data and saying, look, it doesn't work, or look, it does work. And is that because it's just inconclusive, or what?
No, there's some really good evidence. California is a good example. Ohio, several other states. Here where I live in Massachusetts, they have minimum staffing standards. The literature generally suggests that when states put in these minimum staffing standards, it does increase the number of staff in the building. You might say that sounds pretty obvious, but it hasn't led to widespread closures. It's not putting nursing homes out of business. So I don't expect this federal minimum staffing standard to put a lot of facilities out of business. What has happened, however, Stephen, there is some nice evidence that it's improved quality as well. So I should make
That's
that
the part that I'm really interested in.
Yeah, absolutely. Where you can link these increases in staffing to better quality, and that says a lot. And what I will note, however, and you kind of teed this up, every state program is a little bit different. And so some of them have just a broad requirement, all staff per resident day. Some of them have a registered nurse, a licensed practical nurse, a certified nurse aide. And these models have led to some unintended consequences. This won't shock you that, if you have an overall standard, you're going to see fewer RNs and LPNs and more CNAs. They're going to shift their workforce. Another thing we've seen is that if you only require direct care staff minimums, they're going to decrease the number of housekeeping and dietary and other staff within the building. And so there are some ways in which nursing homes have tried to adjust to this, but the overall effect has been higher quality. And so I do think there's good support. And the final point here that is really interesting to me is that every state is unique. And I spoke recently in New York State, and they're super worried about the LPN rule there, and because this federal law makes no requirement about LPNs, as you know, yet
That's
New York
right.
State doesn't have the med tech, so they have to have LPNs doing that. And so New York nursing homes are very worried about how they make that work. In other states where you have the med techs, you're less reliant on the LPNs. There's a workaround. And so some states the requirement may look very similar to the federal requirement. Other states, it may pull nursing homes in two different directions, and it's going to be very challenging, I think, for nursing homes in those states to both meet their state standard and also this new federal standard.
So why? I'm going to ask it in a way that's probably politically incorrect that you wouldn't be able to ask it. But it feels like sometimes when the federal government, the regulators make rules, they don't do it in a very thoughtful way. So this example that you just gave, I sort of sit here as you're talking about it, and I'm thinking, why are they such idiots to not realize that they're creating a brand new problem that's going to be really, really hard to fix? And how do we get past that?
Yeah, so to the first part of your question, I think a lot of us immediately saw the potential for unintended consequences, and I'm referring to as you are, to the exclusion of the licensed practical nurses, the LPNs. By not requiring that, you're basically leading probably to nursing homes meeting the RN requirement and then filling the rest of the facility with CNAs. LPNs are so important. If you've ever been in a nursing home, you know they're a key part of the
Oh, yeah.
the quality process. And the idea that we're just going to take this out, it makes absolutely no sense. And so, I've said about this policy, if you had left me in a room and just said, come up with 50 different versions of what this minimum staffing standard might look like, I don't think I would have ever come up with the rule they did, where you have RN requirement, a CNA requirement, and no LPN requirement. And so we gave this feedback to CMS. A lot of people, it wasn't just our group, it was others. They chose to go forward. So now what do? I know they claim they're going to monitor for unintended consequences, but I really worry that we're going to lose these LPNs. And Steve, once they're gone and working in the hospital sector and elsewhere, are they ever coming back? And I don't know. And I think especially in states with med techs, I wonder if they're just going to eliminate this position altogether and just have RNs and CNAs.
Yeah, and what ultimately, as you point out, what it really does is it just makes the overall staffing problem worse because it drives people out of the industry. One other thing that I struggle a little bit with, and I'll throw this maybe like a good place to kind of, as we're running out of time, is I'm a believer that as an industry, we have to be realistic about the fact that we have some really great operators, some middle of the road operators, and we have some crummy operators. The industry tends to say, well, all boats go up with a rising tide, and we shouldn't say we should. In my view, I'm going to, my prejudice, my perspective is that we ignore the bad players. So I look at some of these stories, and in my view, we as an industry should say, hey, that's not us. And any thoughts on that?
I love where you're going with this, and you could use it on almost every issue that we've touched on today, but especially kind of the assisted living. There's lots of good apples. There's some bad apples. Shine a light on those bad apples. Same thing with how are nursing homes spending their money? Are they putting it into direct resident care? Are they putting it into these related party transactions? The good providers should welcome this transparency and this accountability. I would be very suspicious of any provider, whether they're assisted living, senior living, nursing home, you name it, that isn't willing to kind of open up their books. Transparency should be your friend. And I've always disagreed to some degree with the industry, where they've kind of kept this united front. And I would maybe this is the wrong way to approach it, but I'd be the first one to point out, hey, those are the bad apples. Let's weed them out. Let's not all too often. Then you get a series of stories in the Washington Post, or you get a series of stories in some other major media outlet that documents, and everybody gets kind of painted with this same brush. And hey, you could tell me, Steve, well, you're always going to have some bad providers, but some of these, and I'm thinking of the Skyline example in nursing homes, where you just have these egregious examples. How is that allowed to kind of foster, to grow and become a model? And I think the industry could take some steps to kind of monitor their own. I love that idea.
Yeah. And during COVID, there was a nursing home in Southern California where they had 13 CNAs scheduled and 2 showed up. And honestly, my thought was, we as an industry, we should say, that's not us. We want licensing to go shut those people down. They should not be in the business. I'll go out on a little bit of a limb. That one of the Washington Post stories had told the story of a building in Colorado, different ownership today. I'm going to start, so I'm not going to name companies, but where a resident wandered outside at night and in the snow and could not get back in and died. And we should not make excuses for that. Now, the Washington Post got it wrong. They said it was a staffing problem. We don't know that that's true because the 2 staff who were on were apparently off smoking dope or doing something. And so if you'd had 4, they probably would have been off smoking dope together and it would have still happened. And so we've got to be realistic, but we got to call that stuff out. So,
yeah, I think that the last part of your statement there, it's about transparency. Call it out. I would hope that, industry has tended to be very I don't know, reticent to take on additional oversight, but this is a little different. This isn't, hey, you have to have X, Y, and Z surveys a year, and you have to have additional reporting requirements. This is about kind of transparency in who owns the building, how they're spending dollars. I think that would go a long way towards helping the reputation. And I think all too often the reputation of, whether it's 15,000 nursing homes is driven by a few hundred places that are really providing egregious quality. Maybe more than that, maybe 1,000, whatever it is. That sort of bottom decile is really moving the narrative.
Yeah. And the last thing I would add is that there are a lot of great stories, and we ought to be telling this. I gotta show you my shirt here before I take it off. This is a brand new advertising campaign that Aegis Living out of Seattle is doing. They have a beautiful commercial. I posted on my LinkedIn earlier this week, where you can find it if you're on LinkedIn, and it's really cool. And so they sent me their when I got on my team meeting that we do every Friday morning, and I was showing them my shirt, they said future. Ouch,
right?
Yeah. So my little ageist teammates, it was really good. David, this has been a great conversation. I appreciate so much you're taking the time. I appreciate what I love particularly about you is that you're passionate, you're a fan, but you're willing to tell the truth. And I'm afraid that's in short supply.
Well, thank you. This was a great discussion, and I would love to come back and do it again.
I'm looking forward to it. So with that, we will see you back. We're actually doing another health policy kind of conversation next week with Dana from the Erickson School, and it'll be another great conversation. David, thanks again. Have a great weekend. Hang on for just a second, and we're done.